please return back to your seats. We have our next speaker. I'm pleased to introduce Dr. Carlos Moreno. Dr. Moreno has had his training at Memorial Sloan Kettering Cancer Center at Cornell Medical Center in New York with emphasis on molecular pathology. He has passed a clinical professor at Michigan State University. He is currently the CEO of Vida and Salud in Crystal City. May I introduce to you Dr. Carlos Moreno.
Thank you, Olga. Good morning, everyone.
Good morning.
I will start off by telling you that if you have driven on Highway 83, it is everything that they say. Because this morning I drove from Laredo here, and it is as close to NASCAR as you can get. I did see my life flash before me a couple of times. Well, it gives me great pleasure, and I thank Olga, I thank everyone for inviting me again this year. This year we're talking a little bit about Alzheimer's and co-morbidities. Well, we ask ourselves, co-morbidities, as if a disease process or anything that ails us isn't bad enough. So here you have a disease process, Alzheimer's, and then you add something else. A disease process that now exacerbates or increases the likelihood on top of everything else that is in a person's life. Okay? So, disease and degenerative brain diseases were often seen as obscure and intractable maladies. That's the way science, that's the way medicine saw for the greatest amount of time what ailed the human brain. And so Alzheimer's was found that, on the molecular part, there were 4 genes that had the familial Alzheimer's disease levels. And so we could get into it in great detail, but that's not what this is about. That's not what this conference is about, because, the amyloid beta protein and the elevations, and there have been discussions from multiple aspects. Duke University, back in the 80s, when I started with molecular pathology, it was in its infant stages, back in the 80s. And molecular pathology was trying to diagnose what the eye couldn't see on the molecular level, and seeing what was happening as far as disease processes in the organs. And so they started finding out that accumulations or plaque decrease certain levels of circulation. Well, there's a number of theories out there, so much that most recently they've been discussing that even the statins, your Lipitor, if you have high levels of cholesterol, that if we could all be mice, all disease process would be solved for the human race. But everything works on mice, it's never transferred over to the humans. And so there's been discussions that, treatment on statins, that could be a possibility. Any other issues that hit a human throughout their life also impacts the quality of their life. These are very interesting things to look at. It's been found that the ratio, most likely if you are over the age of 65, 1 in 8 individuals more than likely will develop the Alzheimer's disease. Your ratio goes even higher, lower, that 1 out of every 2 individuals over 85 will progress to the disease. And then, of course, there's the familial. The course is gradual. It destroys memory, language, and other cognitive functions. I am going to share with you, not only on the medical side, but on the personal side, 2 key individuals in my lifetime that I was personally very close to, and how this disease process also affected their lives, our family, and myself. Okay, if we could go to the next slide, please. So, below, previously, it's approximately about 5 million Americans, and growing. 5 million Americans right now are growing, and especially baby boomers, never to be considered as part. This is very, very important right here. For clinicians, for the general population, never consider Alzheimer's disease to be part, or to even be considered as part of the aging process. This is a disease that we have come to a certain degree, gotten to know either very closely and personal because of the frequency. It's like cancer. When we start saying the word cancer at some particular point, I do this quite often, sometimes in presentations. I ask everyone to please stand up, and I mention the word cancer, and I say, if anyone here in this room has been touched, knows someone, has been diagnosed with cancer, is a survivor in any capacity, you know anyone that has been afflicted by cancer, please sit down, and pretty much, I would say 99.9% of the population sits down. That's where this is growing. Okay? So, Alzheimer's disease and comorbidities, well, the elderly. For the standard of clinical care for clinicians, diagnosis and treatment of any comorbid medical conditions, and we're talking about diabetes, cardiovascular disease, any other disease process that they're being treated for, has to go hand in hand with the diagnosis of Alzheimer's disease, and they're not separate. You do not separate the two, because they go hand in hand, because as the disease process continues, the other chronic ailments also continue. It was found that patients with Alzheimer's disease that were hospitalized have an average of 7.97 comorbid conditions. That's other ailments also debilitating and creating havoc for the rest of the quality of their life. Diabetes and cardiovascular disease, and in here we have congestive heart failure and basically ischemic heart disease, are among the top two. Again, diabetes and cardiovascular disease. Then we also have, these two are positive predictors for mortality. Cardiovascular disease and pneumonia are very common causes of death. Very. And then you have the natural other issues, fractures of the femur, musculoskeletal, and general urinary disease. Most oftentimes, and something that has to be very cautiously, especially in the nursing homes, are UTIs. Urinary tract infections will mask and will mimic. Someone, especially a patient, an elderly patient with a urinary tract infection, if it's not treated, the exacerbation of symptoms will mimic everything that you will start seeing in a patient that has Alzheimer's. Okay. So, we also have the psychiatric comorbidity conditions that are very common in conjunction with Alzheimer's. And among those are apathy, depression, insomnia, psychosis, and anxiety. Let's look at this, anxiety. We're all going to take a step back this morning and forget about Alzheimer's. Think about your own personal lives. Now let's start from the beginning. You get up, right? You have your rituals. Some of you, it takes a little while to get the motor going. You get up, right? You're gonna say, well, I gotta get the coffee going, I gotta do this, I gotta do that. What about you get out of bed, you're right on the edge of bed, and you don't know which way to go. You have no understanding or clear understanding of which way you're going. Did I just go to bed? Did I just get up? What do I do? What room am I in? Whose house am I in? It sounds, do you start feeling the anxiety getting to you? And then on top of that, okay, you get up, you go put the coffee on, you forget to put water in there, you leave this on. Now all of a sudden, smoke detector starts going on. Okay, what do I do now? Panic, anxiety. Do you see? And you haven't even just addressed moving out of your own home. It's become, you know, I take it very personally when I hear a lot, especially when we talk about Alzheimer's, because to a certain degree, television has become, it's kind of been taking this set where they put a camera and they think it's a funny disease. Humans kind of laugh. We all laugh. If I fell right now, there might be a chuckle. But you know what it is? It's nerves, because we all see me fall and go, thank God it wasn't me. Right? But people look at this where, you know, a man gets fully dressed in a three-piece suit and he has his underwear on the outside. He forgets what sequence the clothes go on. These are things that as practitioners, as just caretakers, we have to be very vigilant that these are signs. You don't necessarily have to come out and say, well, you have this, you have memory loss, this. Just look at the person's hygiene, the way they communicate, they don't communicate, the way they walk in, the way they interact, the way they have decreased in their ability to function. I will tell you on the two personal notes. One is the person, one of the persons that I love the most, passed away, my grandfather. He was my hero. Man, 6'1", very robust, strong individual, very independent, and gradually he deteriorated to nothing. Such that my grandfather, he died at 88 years of age. In 6 years, he progressed to a shell of a man. And I will tell you what progressed. It became more and more difficult for him to drive, as it was explained earlier. He wound up lost from the house, 3 blocks from a house he had lived in 40 years. He was at a gas station, he broke down, he was crying, and police came and did not know which way to the house. We couldn't tell him, and we could not, he refused. He became so indignant on the fact that no one was going to stop him from driving, so we had to do something. We had to take the battery out and tell him that the engine wasn't working and that the car had fallen and wasn't workable. Then he was like, well, let me go look under the hood. No, so you can't do that because, you know, these new cars, you know what, we took out the battery. So now he was like, okay, you take the battery, I'll take the bus. Next thing, he got lost on the bus. He escaped one day. We didn't know where he was at. After that, found him. 2 years later, he got lost within the neighborhood 4 blocks away, and he was lost for 2 days. And a family took him in and cared for him until finally, we had flyers and posters all over the place. And they were sorry that they hadn't been so attentive, but they saw him and he was disoriented. And when we went to go pick him up, I kid you not, he was sitting at a table and he was happy because they had provided him candy and some things, and he was just like, he looked at us and could not even recognize us, really. And he was okay with just the fact that, they had given him something to appease his ability to just be there. That's it. Took him home. Candies became a very big thing, but little did we know with this problem with diabetes, okay, were we helping it or worsening it? And then on top of that, when it was time for a bath, he would hide like a little boy. I have remember when he was a little boy, we find him in the closet hiding away because he didn't want to partake in a bath. Slowly and degeneratively, yes, pneumonia took him, as you will see, as we've talked about pneumonia. And yet, he did have those anxiety moments. Here's another interesting personal note that I share with you. A colleague, a very dear colleague of mine, brilliant neurosurgeon. I taught with him. This one is real anxiety. Picture yourself, this is your profession. You're a neurosurgeon. You know everything pretty much there is to know about the nervous system. And you start recognizing that you have the disease. Now all of a sudden, he started seeing the degenerative process occur for him to the point that he actually developed an entire work plan, as methodical as he was, at what point he was going to be institutionalized in assisted living. Then, when assisted living didn't work, where the next and the next and the next. And what he did for the university, once he did this, he started as his tribute for mankind, he started a log every single day of following the degenerative process so that he could pass this on. And the moment, what he instructed us was that the moment that he stopped logging in the findings, what he was experiencing, how this whole process and the whole 9 yards, that we could take this and hopefully with this start working and understanding the disease better. Because once he stopped, he says the disease has won. I will tell you another part that affected our team, that we were about 4 of us that worked very closely. Always, and I use this as a teaching moment to, if you're a practitioner in any capacity, have the ability that sometimes you share among yourselves information. We learned a very tough one. He came in one morning and presented a PET scan. And he said, "What do you guys think?" And he put it on the table. And we all looked at it and go, "Wow, this is really bad. This is very progressive." And we see that the cortex this is not good. By the way, whose is it? It's mine. Okay. So, lesson to be learned. That was another one. That's something that I always ask individuals, that if you're ever in the capacity or anything, someone passes you some information, what do you think of this case? Think twice and first ask, and who are we talking about? And that one was a tough one. But those 2 case scenarios, because Alzheimer's, it was a topic that was asked, I said, sure, I'd love to share a little bit about what I know about disease. Let's look at this. Quality of life is affected, but also the life of caregivers. How many of you have heard the term coined sandwich generation? Okay, you all know what it is? You're sandwiched in. You're a caretaker. You're caring for your parents, and you're also caring for your own family. And you're like a peanut butter sandwich right in the middle. Who do I take care of? I have the needs of my parent with Alzheimer's, and then I've got a recital and a football game to go over here. Who do I go see? I've got, my parent was just right now hospitalized, and my spouse is also in the hospital. This starts taking a toll, again, on the physical conditions, the anxiety, the emotional, and the support. And the network starts getting smaller and smaller, so this generation starts suffering comorbidities as well. Work with families, culture. We have to, in order to work collaboratively and collectively, and most importantly, effectively, we have to understand the culture that we are supporting. Okay? We do know and we recognize, especially here in Southwest Texas and in our area, do we have very many nursing homes? No. Most of nursing homes are non-existent, and it would be, to a certain point, to the Hispanic culture, very disrespectful, because you don't place your parents or someone in a nursing home. You take care of. So then, if you're lucky enough, and there are enough family members, each one shares and collaborates so that you don't get sandwiched in. But what about those individuals that don't have a major support network? That's the other part. Specialists. So you have to work with, the specialists are key. Because if you have comorbidities that do require special care of attention beyond the primary care provider, they have to be in the loop in knowing the types of medications and what you are treating this patient with, so that it is a unified, synchronized treatment plan. The current meds don't reverse dementia or stop it, they just delay the progression. That's really all it is. It's just a delay in the inevitable. But you do your best, and the earlier the onset of the diagnosis, and the earlier you start the treatment, the longer you could possibly prolong the progression. Okay? So, the main important symptom is that short-term memory loss. Why is it that for most individuals, when you are talking to them, they can tell you in 1937, I was wearing a pinstripe suit with white shoes, this, that, and I'll tell you exactly at 7:02 what I was doing. By the way, Gramps, what'd you eat? Huh? When are you going to give me breakfast? I just gave you breakfast. No, you didn't. I'm waiting for my breakfast. Or they don't remember anything that just occurred within probably the past few hours. The possible signs: problems learning or retaining new information. And that's one of the biggest things. How many of you have seen and are now, it's a big thing, especially not on the internet, but also on TV, luminosity? Yes, it's gymnastics for your brain. Yes, keep your brain fresh. You can log into this thing and you can do kind of gymnastics. Simple math, playing puzzles, this and that. It does help. It keeps you active, it keeps you, because what happens, there are some people right now, there was a study done that said, how many of you right now, knowing the possible genetic makeup in your family history, would actually go get tested to find out what your likelihood chances are, genetic-wise, if you are predestined for Alzheimer's. And so a lot of people are going to do the genetic testing, but then the scary part is, okay, now I know, now how does it affect my daily operations? And they're finding out that the first year, you're kind of okay, but as time goes on, that just knowing what you know now that you didn't know kind of creates a level of anxiety. So it's kind of a cautious double-edged sword. You have difficulty with complex tasks and multitasking. You have trouble functioning at home or work. Daily tasks become a huge. And what happens when you can't do something and you get frustrated? Also depression hits in. And then disoriented or trouble driving, or even judgment. Which way do I go? Do I go here? Do I go now? What is it? Is it I go on green or go on red? Yellow? Which one of these what do I do? So, more issues. Difficulty with language. Now, why is this important? Starts with word-finding difficulties. If I'm coming to you as my provider, how do I communicate? How do I tell you what I'm feeling? How do I tell you how my day was yesterday? How does my provider, how are they able to better understand the progression of what's going on? Unless your provider is very astute, keeps very methodical notations, follows, knows all the idiosyncrasies, knows you on a personal level, and has a point of reference that they can take from here to the next. So on the providers aspects and on the caretakers, a caretaker probably, from my own personal experience, from colleagues and from individuals that I know, they say the greatest possible help ever a caretaker could do, other than, you know, changing, bathing, and feeding, is buying a notebook and keeping a log. A logbook brought to a provider will tell everything that they most likely will need, because it's in detail. You put a date, you put a time, they go through it, and it's like a novel. Look, I can see from Wednesday to Friday there was a progression of this, and wow, they took a drop. What did they do on Friday? Let me look. Wow, they went and they went to a big party and they just gorged themselves in this. I could see where they got sick. Now they have GI problems. Okay, we got that. But a simple notebook, keeping a log, and you don't have to go extensive, just the most basic and things that stand out. You know, today they weren't feeling well, and it was, you know, 2 days after they started their meds, or they changed their meds, or they went to the doctor. So the logbook is one of the best things. Then other behavioral problems, the patient's mostly irritable. They are irritable because my grandfather, he couldn't take the fact he couldn't drive anymore. And you guys took the keys away. And I'll show you. And then inattentiveness, I'm sorry, you know. Hello? Hello? I'm talking to you. Dressed moods, one moment they're okay, the next one, you know, they fly off the handle, and then apathy. Okay? Am I done?
It was a wrap.
Should have gone to the next one. Okay.
Go ahead.
Okay. Now, let's come to two of the big problems. We said diabetes and cardiovascular disease. Diabetes and cardiovascular disease. Why is this? Look at this. Over 21 million Americans have diabetes. 54 million US adults have prediabetes. That's just elevated blood sugars that just don't fall within the norms. 54 million. We have more than 6 million people that don't even know they're pre-diabetic or on their way to being diagnosed as diabetic. And then failure to measure insulin levels is a complicated and very costly thing that most times providers do not do. And why do we emphasize the part about the insulin? Because you can either have insulin that just doesn't do the job anymore the way it was supposed to. So as such, with the insulin, we have a problem that, again, it's one of the, it could be a key metric that we could use. But then we really focus on the most common type of diabetes that's developed, especially at a later time, is the type 2, which is most often time associated with lack of exercise and overweight. So with that, we also find that there's a great correlation being found with the type 2 diabetes and Alzheimer's. For our community, in the Hispanic community, Hispanics of all the ethnicities have the highest propensity and the highest frequency for diabetes. So we also have that if you are pre-diabetic or diabetic, it increases now the likelihood, without the familial part or the genetic part, increasing your chances now going towards the Alzheimer's. We also said that diabetes, because of its entity, increases the risk of heart disease and stroke. So with this, we have to focus on more pressing issues, okay? Please do not leave this presentation saying, I have diabetes, I have Alzheimer's. No, it's just that there's a correlation being found, and it's a very important correlation that needs to be further taken seriously. because anything that we do, what do we do? No. You know, going to the fair and having 6 very greasy fried tacos, we know that that affects our cholesterol. We know that that puts us at risk. They taste so good, and it's really tough to find an alternate imitation or substitute. But there has to be a modification in some way, us to better take care of ourselves. So knowing what investigations are undergoing, what type of maladies are out there, it's up to the individuals, but now you have to start creating this rapport and this education with your community, with your patients, and individually within the care team. Okay? Remember that, are you going to spend for the most part, are you going to spend time going into the intricate complexities and modifications of diet and blah, blah, with the patient? We just said short-term memory loss is the biggest thing, right? So you have to start relying on the caregivers, have to start relying on the care team, you have to start relying on the educators, and on everyone that's on that social circle that's going to provide support. Because it's going to fall on deaf ears if you're going to try to convince the patient, otherwise than them kicking, screaming, and getting aggressive with you, that you're doing something on their behalf if they're very accustomed to their lifestyle. So the education, the follow-up, the treatment plan, everything is correlated with what you are envisioning. So you have diabetes, and then you have the cardiovascular disease. So the cardiovascular disease is most times is congestive heart failure, ischemic heart disease, which are all intercorrelated because again, you have the predisposition. If you have, I inherited very poor genes. I can look at a magazine of something greasy and my arteries are freezing. And I run and I exercise, it doesn't help. I mean, it helps to a certain part. Imagine if I didn't. But for those individuals like myself, imagine if I didn't take being physically active and doing the things I did, I'd be in a lot of trouble. And I take statins and the whole 9 yards. There are just some predispositions and some things I can't change. So knowing that, and knowing that the frequency is increasing, and we know right now that you don't, and for the most part, it's putting, and I'm saying right now, they're saying 65 and older. They're finding out that younger and younger individuals, starting in mid-50s, are starting to get pre-Alzheimer issues. Those are the kinds of things that we have to be astute and very clear and conscious that, there is no specific number. Now, you have that correlation of issues, now we start getting into the realm of, okay, I got to take this seriously. It's when you have that come to Jesus moment that, the scare. Everybody reforms when they've had a life-changing experience. And I promise I will not do this ever again if you get me through this one. Okay? Okay? But, there are abundant states. Let's look at this from a different aspect. All those signs and symptoms that I put up there, forgetfulness, can't function, can't move forward, can't retain. That sounds like, a teenager who just came from, a week of partying in Padre Island and waking up with a hangover. Right? And they're young and they're resilient, but they are incapacitated. And now imagine your life is like that every single day. That's pretty scary. That's a cold bucket of water over your head, because it puts you into a perspective that you have to try to understand. So, from what I can share with you, this is a collaborative effort that requires a lot of attention, a lot of care. a lot of vigilance, a lot of attention to detail. When a patient can no longer care for themselves, comorbid issues are all the other diabetic issues, such as the hygiene, the foot ulcers, the leg ulcers, disorientation. High levels of sugar inside the body cause inflammation. They swell the body. And imagine that kind of swelling occurring on the brain. So that's what causes it. Many years ago, when we first started, I worked on a project. And this project, I'll just share, we were working with molecular, it's called fibroblast growth factors, and they are entities all within our circulation in our body. Fibroblast growth factors are correlated with something called angiogenesis, which is they help create circulatory systems. So I was working with a prominent, he was professor emeritus at the University of Israel. He came to New York. And we were working on fibroblast growth factor and the correlation of where we could find them and where they were highly concentrated. Because we were doing brachytherapy, which is radioactive little portions of radioactive material about the size of a rice grain. They would be implanted under the skin, under the muscle, near the axilla, especially for women with breast cancer. And as such, we were finding that certain patients did well and other patients didn't do well. So came the question, some of them are creating a good collateral system, some are not. What could this mean? So we started taking muscle biopsies, and sure enough, certain patients had high levels of FGF. So when this circulatory system was being compromised by the radioactive, it kicked in, it created collateral circulation, and the patient did well. And in fact, the patients that generated more collateral system got better circulation and actually took the radioiodine uptake. The treatment went on, and wow, we were fine. But what Dr. Feldman said, Michael Feldman said, where's FGF the greatest? And we went to the brain, and sure enough, it's rich in protein. I mean, it's one of the best. And the brain just happens to be, after the heart, the most selfish organ in the body that does not take, I'm gonna cut the circulation for a couple of seconds because I'm taking a break. The brain cannot function, cannot survive. We all know this. When a patient is down, are they breathing? And if they're not breathing, how long were they down? Because usually they're going to have sequela because deoxygenization of the brain. So his theory was that we started looking at some brain samples, and we did start seeing that in the older patients on those, there was a decrease of FGF. Now, this was research that we did 30 years ago and nobody ever picked up on. And, but it was very interesting as I think back now that for me, personally, I think that we have found that there are plaques there in the brain that decrease circulation by the statins that's by the clotted arteries. I think that over the process of years and years and years, the brain flow starts decreasing deoxygenization. The brain starts having certain effects as a result of that deoxygenization. And then on top of that, you look at the sequela that ensues after this, and you start seeing this process. So it's kind of interesting that something done so many years ago, there have been great studies, and it all started with molecular pathology so many years ago. But, we've gone to the moon, we go deep sea exploration, find the Titanic, we're finding, right now under ping system in 15,000 square miles, a little box in the middle of the ocean for an airliner. But no one undertakes the most difficult of tasks right now, which is understanding the human brain. And that is one of the most complex organs to understand, because we only use in our lifetime no more than 10% of our capacity. 10% of our capacity, and that is even in the geniuses. And so it is something that it's here. It is only going. I greatly appreciate this fact that we have all gathered here, because there's great interest not just in Alzheimer's, but in mental health disease, and more so for Southwest Texas. As the Chief Executive Officer of the Vida Salud Health Systems, we're a center, and we're located just like in Eagle Pass, there's United Medical and Community Health here in Uvalde. We all serve, and our focus is primary care. But one of the most underserved areas that is alarming to all Southwest Texas is the lack of resources for behavioral health. And in that, the support that we can get. Because again, we're trying to find the resources, the ability to find referrals, the ability to find slots and access for our patients. Because most of us here right now are listening to these discussions. Okay, we diagnose someone with Alzheimer's, we diagnose someone with organic brain syndrome, with the degenerative. But where do we send them? What resources do we have? About 6 months ago, I heard the interesting statistics at a very big meeting, and this is kind of alarming, that between Dallas and Del Rio, there are only 47 licensed practicing counselors, LPCs, certified counselors, only 47, of which not even half are bilingual. So these are the kinds of things that, along with the disease process and our clinicians and trying to understand the disease process, we also need to be more cognizant, vigilant, and seeing what else within our community, within our professional endeavors, we can do to help our community. Because once these diagnoses and these processes begin, what now? What resources do we have? So, how am I doing on time? 15 minutes, well, this is a good time. If we have questions, maybe I can answer. But again, this wasn't more of, that was my presentation, 6 slides. It's just, this was more of a dialogue, a discussion. Because the subject matter is so complex and so in depth, that if we could just leave here with the main concept, the short-term memory, that diabetes, cardiovascular disease, pneumonia, those play. Alzheimer's is not part of the aging process. It is not to be taken lightly. It's scary, and think of yourselves, just on a general concept. If your life today, basically every hour you forgot what you just did, how scary would that be? And what do? And then on top of that, for your caregivers, for your practitioners, for your medical staff, for your care team, how can they be best aligned with their resources and their knowledge to help you or help your loved ones in putting forth the best possible way of a treatment plan? And the treatment plan is not separate. Alzheimer's is not separate from your medical conditions. They go hand in hand, okay? And then because they are hand in hand, they need to be seen as one. Yes, sir?
Do you see any correlation between our environment today, either pollution or jobs or whatever else, is this coming up to be a bigger deal now than they
Yes, sir. Anxiety. Your anxiety level automatically brings all the cardiovascular issues also. The stress levels, There was if we look, when I was growing up, we had no problem. There was six brothers and sisters, 2 parents, in a 3-bedroom house with 1 bathroom, 1 car, 1 TV, okay? We made it, we survived, we lived okay. There was a fight every morning who got into the shower first, but we made it out. But you know, my dad still had time for us on the weekends. There were the things that we needed and we didn't go. Today we are very stressed because everything is about nanoseconds, not seconds, nanoseconds. You know, if your iPhone doesn't give you an answer in 0.01, boy, is this thing slow. We've lost patience. Think of the stress level right now just driving on 83, the congestion. And this is just everyday life. And then on top, you know, it's very interesting correlation that today, do you know how much stress a person has when they work a full-time job? Anybody take a guess? 62 hours a week, their stress level goes up. I'll explain. If you hate your job, your stress level starts at 6 a.m. for an 8 o'clock start time. So you started at 6, all right, in anticipation of where you're going to go. You work an 8-hour job, right? So now you got 10 hours, and it takes you an hour to desensitize and on the drive home, hoping that you don't have stress on 83. When you get home, to kind of cool off. That's 11 hours. Times 5 is 55. Now, your stress levels start building up in anticipation of Monday morning when you hate your job at 6 p.m. Sunday night. Take that to the next morning. Multiply that by 52 weeks, unless you take vacations or not. Okay? And could you imagine an engine, even your car engine, you wouldn't even run your car engine that poorly because it would overheat. And that's not even a New York City cab that drives 24 hours a day, 300,000 miles, you know, a year. So yes, stress is an behavior. Yes, ma'am.
Well, just, I'm wondering, I don't know what all of Obamacare provides, but are you familiar, is our healthcare system going to address Alzheimer's or some of these caregiving, you know, issues and Medicaid, you know, all the
Not getting into the crux of everything, and I understand. Our health system needed some change and some corrections. We all recognize that if we don't fix something, yes, the first thing, when I take away your favorite, you know, fruit or something, there's going to be pushback. The fact is that healthcare and behavioral health has been recognized as a key important part. I would gladly, and I would roughly say between 60 to 70% of patients coming into primary care, any primary care, are carrying, in addition to that, some type of mental health issue, anxiety, depression, or some type. If we could start addressing those behavioral health issues in conjunction with our primary care, we would fix a lot of problems, because the patient that currently right now is coming in with a blood pressure of 140 over 90, 140 over 110, probably has a lot of other issues that are ongoing home. And if we could take care of those problems, we would probably, in conjunction with the medicines, bring it down eventually to take the medicines away. So there is a lot that could be done. And yes, that healthcare does recognize that the cost of a patient, especially with a lot of, or an anxiety attack at 3 o'clock in the morning, is not the most cost-effective way of, you know, hospital addressing an emergency room. All right, yes ma'am.
Quick question.
Sure.
Because I know you said that diabetes ties into all of it, but in the correlation between, you know, what he was talking about, the foods now that we have, and the foods that we're bringing into the grocery store, and all these preservatives now, do you not think that plays a big effect on everything as far as our chemical imbalances and stuff, or balances, or whatever it is in the world?
Absolutely. Because remember, if you go even to HEB or any package, look at the back, and it's anything but broccoli. The broccoli has everything from every type of preservative in there, plus the chemicals that were put within the fertilizer, unless you're getting so-called organic. In addition to that, our natural foods are not as natural as they used to. I mean, when you're looking at beef that basically is, you know, it has enough steroids in there, you know, one of the most important things, and this was a discussion I had the other day, which was, you know, eating healthy is very expensive. If any of you are or care to eat organic, you go broke, right? And then so I'm very cognizant within our community. Most oftentimes, I wish I could have brought the presentation, but the great majority of patients that Community Health, us, United, and all the federally qualified health centers see across the nation, and there's 1,600 of us, 44% of our patient population is under the federal poverty line, $11,490 a year a person earns. When you have that, and you have no other resources, are you going to care if it's organic or not organic? I need to feed my kids. I need to come in there. And then sometimes what we also have is that the subsidies do not cover, you know, healthy choices. Now, WIC program just recently added nutritious vegetables and things that they can swipe and they can actually feed the families. But for that when you look at the longevity of what people can buy, especially if they have federal funds, it becomes very, very difficult. And yes, the eating part is essential. Yes?
Well, now you've hit a nerve. I am a rancher and a farmer, and let me tell you, if you want to be eating food that is not monitored by laws, you get all these important things from other countries. This labeling, country of origin, is very, very important because we as producers, we have to follow certain guidelines, and our products, especially beef, is nutritious. There's a lot of myths out there, and so just education on the product. I hear what you're saying, and I can't fight it except to say that as a producer, we try to produce the healthiest product because we eat it too, and we do not want to poison our families. But the main thing is this country of origin. If you buy from the USA, we are regulated about what can be used, and it has gotten better through the years. I'll admit, I've been a rancher for 50 years, and in the beginning we didn't have all these beef quality issues, and it's gotten much better. So I believe that the U.S. farmer does produce some of the safest foods in the world, and we feed a lot of people. Each farmer feeds a lot of people. So there, I've had my deal.
Thank you.
Thank you, Dr. Moreno. At this moment, I'd like to, don't leave yet. I'd like to present to you a small token of appreciation for your helpful presentation, and this is from the Alzheimer's Association. It is a picture that was created by an Alzheimer's patient. Thank you very much.
Thank you.
Okay, ladies and gentlemen, I want everyone to stand up. Everybody on your feet. Okay, stretch, do some calisthenics, go out there and get some snacks. We're going to take a 15-minute break. We are going to start at 40 after.